Okie dokie. Hi, everybody. Thank you for coming along to the final in the webinar series for type 2 diabetes for under 40s. And this session is an open Q&A, and I'm joined by two brilliant experts. We've got David Lipscomb, who's the consultant in diabetes and medical head of service in adult specialist care at Sussex Community Foundation Trust. So David, welcome along.
Thank you.
And we have Sarah Gregory, who is a Diabetes UK clinical champion and a diabetes advanced practitioner. So, guys, we have some questions that have been sent in for people who can't attend.
Sure.
For those who are here, please do. I have got the Q&A option open. The questions will be anonymous, and so please ask anything that you fancy. And also what we'll do is just answer some of the common questions that get asked for people who have type 2 diabetes or living with type 2 diabetes, and for those under 40 as well. So let's start. I'm going to start with one of the questions that we've got sent in, and then I'll have a look and see if any questions are sent in on the chat. So one of the questions is about, we hear talk of reversing diabetes and people who've said that they've reversed diabetes. Does that mean that diabetes is cured if you talk about reversing it? Who would like to go?
Do you want to start, Sarah, and then I'll chip in?
Yeah, that's a good question, actually. And what I would say is that the work that's been done around remission, and it is remission, not a cure, because we've still got that metabolic memory. So your body's going to remember that you've had type 2 diabetes. But the term remission came around with some work done by a very clever man called Roy Taylor, who found that if you dropped a fair amount of weight, reduced that sort of liver cycle that leads to diabetes, and adopted the diet and lifestyle interventions that he worked on, then you can put diabetes into remission. The best target time to do that is as soon as possible after diagnosis, because what he found with his work, that up to about 6 years and beyond, you're kind of losing the impetus to be able to put your diabetes into remission. And there is a remission program that David can talk about locally, and it's certainly worth asking your clinician around if you're newly diagnosed and it's something that you want to pursue. So if you can explain what's in Sussex, David.
Yeah, of course. Yeah, I'll do my best. So yeah, just to expand on what Sarah says, I agree with everything she said. Is that, so Roy Taylor from Newcastle and a guy called Mike Lean, wasn't it, from Glasgow? They spearheaded a lot of the work on this, and so it very much goes back to the pathogenesis of diabetes. So why does diabetes happen to some people and not to others? And we've all got, which is largely genetically determined, so we can blame our parents, what they coined the personal fat threshold. So in other words, if we get overweight generally or larger, we will then start to store fat, not just under the skin, subcutaneous fat, but centrally, and in particular, as Sarah says, in the liver and also in the pancreas. And what they showed very, very beautifully, to be honest, is that by losing weight, and they use lifestyle, and there's other things that we can talk about as well, by lifestyle change, and in their study, the direct study, quite radical lifestyle change, and this is what the diabetes remission program's based on. It's essentially full meal replacement, so you go on to soups and shakes, around 800 or so kilocalories a day with some green vegetables for 3 months. So it's not for the faint-hearted in terms of the change in lifestyle that that is required. And what they showed is that you know, in the first year, people that lost around between 10 and 15% of their body weight remitted their diabetes. So we use the word remission rather than reversal, I think. They brought their glucose levels, or their HbA1c, which is, you probably know, one of the measures that we use in clinic to measure long-term glucose levels in people's bloodstream. They brought those back to in the non-diabetic range in over 50% of people, particularly in those that lost weight and kept it off after food reintroduction. The other main area that's been studied in terms of diabetes remission is bariatric surgery. So surgery to help people to lose weight permanently by changing their plumbing, essentially their internal plumbing of their gut, which means that they neither absorb food in the way that they did, and often restricts the size of the stomach as well. And those have been shown to be very efficacious in terms of remitting diabetes in the long term. By the long term, I mean years and years of people having normal glucose levels. And again, like lifestyle change, that's probably more effective the sooner after diagnosis that those things are considered. And that starts to make us think, why is that important? So type 2 diabetes is a progressive condition. So what caused the diabetes in the first place will continue to happen over time. And that's why very often people need medication. And sometimes, in fact, very often, they need more medication as time goes on, because the beta cells, the cells in the pancreas that are making insulin, get less and less as time goes on.
Okay. So
sorry, Fran. And then
no, sorry.
Go on.
No, you go. Sorry, I thought you'd stop talking.
And then in terms of the remission program, that's something that only your primary care colleague, so your GP or practice nurse, can refer you for. So I'm, as you've heard, I'm a specialist in diabetes, so we're not allowed to refer, although we see people with diabetes. That has to be the GP, simply because that's the way the payment systems work.
Yeah. Okay, thank you. So just in summary then, so it's not that you can't cure diabetes, but you can put it into remission for a period of time, which reduces your risk of long-term complications, reduces your risk of going on medication, or kind of stops that maybe happening sooner than it would, and your GP can refer you if you would like to kind of go down that route.
Absolutely.
Brilliant.
Yep.
Okay, fantastic. Another question that we've got is around around medication and around insulin. So if someone has been told by their GP or their consultant that they need to start insulin, does that mean that their diabetes has gone from being a type 2 diabetes to a type 1 diabetes?
Shall I start again?
You start, Sarah.
No, it doesn't. And actually, insulin is always going to be an option to treat type 2 diabetes at different stages. So we use insulin to, if people are planning a pregnancy, if people have what we call osmotic symptoms, so, you know, are unwell at diagnosis, if people are planning surgery and they need to get their blood glucose levels down. And some people actually find insulin easier, and it should always be on our pantry shelf as an option for treatment for type 2 diabetes. So what we try and avoid is leaving it till last, or leaving it as sort of almost a threat that, you know, if we don't improve things, you'll go on insulin, because insulin is the pathway for most people at some point in their diabetes journey. So, but it doesn't mean that you have type 1 diabetes, because type 1 and type 2 are very different conditions. And type 1 is, you know, you don't make insulin from the start, or you produce very little insulin, and that's because of the beta cell function in your pancreas is damaged. With type 2 diabetes, as David said, it's a slow progressor, and people progress at different rates for different reasons through different circumstances. So, you know, we see some people going on to insulin with type 2 after 5 years, some people it's 25 years, but it's always a treatment option that we use for type 2 diabetes, but you stay type 2 insulin treated.
Right. Okay, brilliant. So it's not a failure if you go on to insulin. It's just, it might be for a number of different reasons. And if we're looking at this age group, you know, you talked about pregnancy as one of those areas that might be a reason for someone to go on to insulin, which kind of leads me nicely into the next question, which is, what about preparations for if someone is looking to get pregnant and they have been diagnosed of type 2 diabetes? Are there things that they need to consider? Because you did mention insulin on the last question.
Yeah. Shall I start with that one, Sarah?
Yeah.
Brilliant.
So yeah, that's a very important question. And so people with diabetes, in fact, people with type 2 diabetes are now becoming much more frequent to get pregnant than in years past. So I used to run a diabetes in pregnancy clinic with obstetricians and people like Sarah, specialist nurses and so forth. And, you know, it used to very much 20 years ago be people with type 1 diabetes pretty much solely in gestational diabetes. That's diabetes that develops during pregnancy and then usually goes away again after delivery of the baby and the afterbirth. But it's now much more frequent that we see people with type 2 diabetes in those clinics, and that's part of the reason we're all here tonight, because it's much more common in women of childbearing potential than it ever was. Now, like most things to do with diabetes, the way I think about it is people living with diabetes can do everything everyone else can do. It just needs more planning to get success. And, you know, I often think of, you know, what are we hoping for at the end of the pregnancy? Well, we're hoping for a healthy baby and we're hoping for a healthy mum. And if we can achieve those two things, then that's fabulous. So in terms of planning for pregnancy, we absolutely would encourage people to talk to their GP or their practice nurse and proactively and say, you know, myself and my partner or whatever, we're thinking of having a baby. And that should trigger a number of actions, such as a review of the diabetes to make sure their glucose control is as good as it can be, to make sure that they're on medications for their glucose control which are safe for babies, because some are not. So most of the tablets that we use outside of pregnancy are not safe in pregnancy. So metformin is safe, and that's used a lot in this country, less so in the States, but a lot in this country in pregnancy. And as Sarah says, insulin, you know, has been our treatment in pregnancy forever. Well, for the last 100 years, I suppose. And those are the mainstays of glucose treatment in pregnancy, and some of the treatments need to be stopped ideally at least a month or so before a planned conception. But we aim to try and get people's glucose levels as good as they can be, balancing fertility at the same time. Then folic acid. So most people will think about folic acid over the counter, which is 400 micrograms as a dose. In people with diabetes, there's a folic acid needs to be prescribed because the dose recommended is 5 milligrams once a day, so a lot more than a sort of standard over-the-counter preparation would give you. In addition to that, often people living with type 2 diabetes that are under 40 will be on other treatments, typically blood pressure medicines, sometimes statins, and those will need to be stopped or altered to medicines that are safe for mum and safe for baby during pregnancy. So there's often quite a lot of preparation that needs to be done, and then discussion around if someone's already got any forms of diabetes complications, what might happen to those.
Okay, brilliant. And just following on from that, what about after they've had, if they've had a healthy birth, and they're breastfeeding and stuff? Are there things that they need to consider at that point as well?
Yes, I don't know if you want to start with that, Sarah, or
okay. No, you carry on. I think.
Okay, yeah. So
I would like to just remind you in primary care about gestational diabetes, but we can come on to that after you've answered Fran's question.
Yeah, sure. So again, similar rules apply in terms of medication in breastfeeding, and again that would be gone through specifically for somebody's situation beforehand. If people are treated with insulin, often as soon as baby comes out, a significant reduction of insulin is needed to avoid low glucose levels in mum, and often people's insulin needs go back to what they were before the pregnancy started, and sometimes less, because breastfeeding takes up quite a lot of calories. So typically sort of say 400 to 500 or so calories a day. So it's not unusual that people need quite a lot of reduction in their insulin if they're on that, in order to avoid low glucose levels.
Okay, thank you. That's really useful. Sarah, what were you wanting to add in?
It's just a note on gestational diabetes. So if you've been diagnosed with type 2 diabetes and you've had a history of gestational diabetes, which is the one where when the placenta's delivered, all that insulin resistance reduces and your diabetes doesn't stay, it's really important. And if you've got type 2 diabetes, had gestational diabetes, what we should be doing in primary care is making sure that we follow you up after that baby's delivered with gestational diabetes. So if you've got friends or family that have got gestational diabetes, please ask them to make sure that they have a HbA1c 3 months after. Normally we in the surgery that I work for, we do it with the baby immunisations so that we can do 2 together. But it's really important because about 25 to 50% of women with gestational diabetes go on to develop type 2. And there is a separate arm of the prevention programme, the diabetes prevention programme, that's bespoke for those women who've had gestational diabetes. So, it may be a bit late for people who've already gone on and developed type 2, but if you've got friends or family that have gestational diabetes, or understanding why your risk was greater, then it's worth bearing that in mind, that sometimes that diabetes doesn't always go away. So that was just the point that I wanted to make on that.
Yeah, thank you. That's really important, and I think probably not as well known as it should be. So if that's something that, if people are watching this and they know of people who have gestational diabetes, to kind of make them aware of that, and to follow that up after pregnancy, I think is a really useful. Thank you. Okay, one question. Obviously we are heading towards December and the weather's got colder. If someone has type 2 diabetes, are they more likely to be at risk of picking up colds and flu and things and other illnesses? And is that something to be aware of? And is there anything that someone can do about it?
Yeah.
Would like to?
Yeah, I'm happy to kick off.
Brilliant.
So that's a really genuinely important question, and it's one that's often forgotten, to be honest. So there's really good evidence that there's a link between having type 2 diabetes and an increased risk of infection, and
Right.
be that viral infections like the flu or COVID, or bacterial infections, and indeed fungal infections. And as some of the people on this call may remember, when they were diagnosed with diabetes, often thrush and things like that can be a symptom or a sign at diagnosis. So those things are known to be more common in people with diabetes. Glucose control also plays a role as well. So our immune system tends to work better the better our glucose control is. So that's another reason to try and ensure that glucose control is as good as it can be, because that will help. And then the third is something that colleagues in primary care do very well, which is vaccination. So protecting, taking all the vaccines that you're offered in order to protect yourself from developing, illnesses that you could have avoided.
Okay, so if try and get good control of your blood glucose levels, and be up to date with all your vaccines, and take any that are offered, are the top tips for staying well during winter if you have type 2 diabetes. Good to know. Thank you for that. Another question we've had in is about can I access the sensors for glucose monitoring? Because I've recently been diagnosed with type 2 diabetes. I'm in my 30s.
So, as much as I am an advocate for sensors, and as much as I would love them to be given out at diagnosis, especially if you're trying to make diet and lifestyle changes and have attended structured education, have an awareness of carbohydrates, our ICBs, who govern all of our meds management, all of our spend, are still following those NICE guidelines, which are the national guidelines, which is say for type 2 diabetes, we can only prescribe them if you're on 2 or more insulins a day, and there's extra criteria as well, or if you're pregnant. So I think David would probably agree as well that actually we would love them to be used much more widely, because when people have had a trial of them, it's actually highlighted some of the changes that they feel motivated to make, and it gives them the results, and they can see those results. And there's no reason why you can't buy those sensors, but the NHS at the moment don't fund them, only for that very specific criteria. And I don't know if you want to add anything to that, David.
Yeah, no, I agree with what you say. So, there's an increasing evidence base around the fact that if you can see what's going on, which is intuitive, then you may make different choices. But yes, but that has, so the way that the NHS decides on treatments, and the way that NICE decides on treatments is based on cost versus perceived benefit. And at the moment, that the evidence base isn't big enough to show that that perceived benefit. The other thing that I think is worthwhile adding is that, it's likely that like most technologies, that these will become cheaper. And as technologies become cheaper, so Sarah and I can probably remember, around the turn of the century, when people with diabetes.
Makes you sound really old.
Well, I was in short trousers at the time, of course. And people had to buy their own capillary glucose strips, didn't they, Sarah? And people would be cutting them in half to try and keep the cost down and stuff like that. And that changed. And I think that's what we'll find over the next 5 to 10 years with continuous glucose monitoring, that it will end up becoming the standard for everybody. But the cost has to be at a level that the public purse can afford it, really.
Yeah. So it's at the moment, like more evidence needed.
Yeah,
General,
yeah,
more evidence
exactly.
needed, and cheaper technologies
Yeah,
hopefully will become
so
available.
it's restricted to people that we know will definitely benefit
Yeah.
now.
Yeah. Brilliant. Okay.
And that's perfectly reasonable, because
Yeah.
you know, the NHS can't pay for everything for everybody anymore.
Yeah, absolutely. Absolutely. Okay, one question about the annual review is the different, you know, things that are that you have to go through with the annual review. Why do you need a urine sample for annual review? Sarah, do you want to
Yeah, I
answer that?
will, because this is something that primary care do. And so the urine sample is called an ACR, and it's measuring the albumin and creatinine ratio, which you don't need to know the lengthy terms bit, but basically it's measuring the structure of your kidneys. So when you go for annual review, you'll have blood tests, and those blood tests will be for HbA1c. They'll also check your liver function and also your kidney function, as well as cholesterol, maybe your full blood count, and some other random that they might want to check. But they're the key things. So what the blood test does, the blood test for your kidneys checks that your kidneys are functioning. Okay, but we see those kidneys functioning on the blood test for a long time before we see things going wrong with the structure of your kidneys. And the structure is your bricks and your mortar, really. And if you get leaky kidneys or holes in that structure, then potentially we start losing protein. And you wouldn't see that to the naked eye. So it's really important that to make sure that your kidneys are healthy, you have your blood test and you take your ACR, urine sample. So if you were to come and see me, for example, and you'd say, oh, I forgot my urine sample, I'd probably ask you to wait in the waiting room, build up a bladder, and then pass me a sample, because it's so important that we get that. During COVID, that knocked off a bit, because obviously people weren't coming into surgeries. But if you're not asked for an ACR, or you don't think it's that important, please, it really is a key part of your kidney health. And your kidneys are just part of the things that diabetes can potentially affect, and they're a big organ in themselves, so it's really important you look after them.
Yeah. So your annual review is essentially really important to look at, you know, as a general MOT for your whole body in terms of how diabetes can affect different organs. So even if things,
and if you're given the option of opting out of your annual review, which some people have been, please don't.
No.
Please don't, because it's so important that and it's free. It's one of the best things, along with your eye screening, that the NHS offers for people living with diabetes. So it's really important that you do that, because that is a marker of other things potentially going wrong. So bring your urine sample, or make sure you do it when you're there.
Yeah, so it's like your annual review is like an MOT for your body with diabetes, and making sure that you're roadworthy, essentially,
absolutely.
and helps to prevent you know, long-term risk and complications.
Absolutely.
Brilliant. That's really, really good. A final question that I've got, unless I have any more. Yes.
Yeah, can I just add a couple of things? So
Yes.
I totally agree with everything that Sarah said. I think of the urinary ACR as like the canary in the coal mine. It can tell you stuff it may be happening years before the blood does. And that's the other thing that's really important, is that you know, we treat people, particularly young people with diabetes, to prevent long-term damage to their bodies. So we know that if you've got persistently, even slightly raised protein in your kidneys, you're more likely to have problems with your heart later on. So so in other words, it increases your cardiovascular risk independently of all the other risk factors we know about, so blood pressure, cholesterol, weight, or smoking, all these things. It adds to that. So that's one of the reasons why we will tend to manage people more aggressively for their cardiovascular risk, even if their glucose levels are fine, if they've got that little bit of leakiness of protein, because we know that those people are at a higher risk of problems, and we are all about prevention. The 10-year plan in England, all about prevention. We've been doing that in diabetes, since God was a boy.
Okay, brilliant. So for those, obviously this webinar series is for people under 40 diagnosed with type 2 diabetes. So it is really important to make sure that you have your annual review to manage risk, to bring your urine samples to that annual review, so that we can minimize that risk of long-term complications.
Absolutely.
And manage
we
that.
Want, from the medical side, from the nursing side, we want people to have as healthier, long and trouble-free life as is possible. And so managing risk, is a big part of that. So if we can help you to manage your risk, that's absolutely what we want to do.
Okay, fantastic. Thank you. So final question that I've got here, unless any more come in on the Q&As, which is quite a nice one when we're talking about managing risk, is what actually is a good glucose level? You talk about HbA1c and keeping them within targets, but what does that actually mean? Sarah?
Well, I don't really like the terms good and bad, because I think that's quite a negative thing to say to somebody. Oh, it's poor glucose control, or you could do better. So you need to know your targets, and you should be set a target at your consultations, wherever you have those consultations, mainly in primary care, because what's good for somebody isn't for somebody else, and vice versa. And I would say if you start off with a HbA1c, for example, that's above target, then it's up to us as healthcare professionals to help you set a target, a final target and an interim target, and B, to support you getting there. Okay, so it's not our decision to tell you what your target should be. We can give you the evidence, and we can tell you the results from studies and the outcomes and risk reduction, but you need to understand what HbA1c is. You need to understand what that risk is, so that you can make that informed decision. So I think we try and avoid the words good and bad, because they can have some negative connotations. But I don't know if David agrees with that, or
I do. I never
David?
use those terms, or at least if I do, I try not to. Because we are not here to make people feel bad. Living with diabetes is tough. I don't need to say that to anybody on this call, but it is tough. And a lot of people, particularly when they're on insulin, will say it's like having another job. The number of decisions people need to make on top of all the decisions everyone else makes is like, some hundreds of additional decisions every day. So it's not our job to make that any harder, more the opposite. So, and again, as Sarah says, we tend to look at different targets from a biomedical side, depending on the person in front of us. So for young people with type 2 diabetes, I would aim for as normal as glucose as possible, without an unreasonable burden of low glucose levels. So I aim to try and get people's glucose levels back to normal, actually, or as near to it as I can, because I want to help people to reduce their risk of problems as they get older, and the way to do that is to help people to lose weight and to get their glucose levels, as I say, as close to normal as they can.
Okay, brilliant. Thank you. So just to summarize then, it's to get them as good as possible, what's relevant and a realistic target for that individual. And that, you know, there isn't such a thing as a good glucose level, because everyone's is going to be different, but as good as it can be for you to help reduce your long-term risk. Brilliant. I have one more, which is quite a nice one to end on. But it says, will there be a repeat of this series of excellent webinars maybe next year? So TBC, but thank you everybody for joining. As ever, this will be available on our website. And thank you both, David and Sarah, for your excellent words of wisdom.
Pleasure.
Thank you.
Genuine pleasure.
Thank you.